I think the most satisfying thing about what I do is seeing the patients come back and just tell me how much better they are, how much less pain they're in, the things they're able to do that they couldn't do before. And lots of patients come in and say that their lives are transformed by having had their hip or knee replaced, which is unbelievably satisfying. So most of the patients who come and see me for the first time will be troubled by pain either in the hip or the knee region. Hip pain is very commonly felt in the groin, and a lot of patients don't realise that initially until their physiotherapist or GP points them in that direction. So most of my hip patients will come with groin pain, sometimes pain going into the front of the thigh and sometimes into the knee, which can be a bit confusing for the patient and us alike. And that pain is usually made worse by exercise or bearing weight. When it's getting to the stage where it's really restricting their activities of daily living, or when they're in pain at night and having difficulty sleeping, then that's certainly when we should be thinking about getting involved and considering whether a joint replacement might be in their best interests. Most of my patients are suffering from osteoarthritis or wear and tear arthritis of the joints, in my case largely the hip and the knee. This is a really common condition. Most of us will have family members or friends who've had osteoarthritis to a significant degree, and it can sometimes come on earlier because of congenital conditions such as being born with a very shallow hip, or perhaps having damaged the hip with sporting activity or accidents in the past. So a proportion of the people I see might have had fractures around the hip as younger patients, and that can lead on to post-traumatic arthritis. It is really common, and a lot of patients are managed in community pathways with painkillers and physiotherapy, walking sticks, graduated exercise, before they get to the stage of their symptoms where they need to come and see me. When I see a patient for a first consultation, I'll spend some time talking to them and finding out about their symptoms, both from the condition that I'm considering and their general health. A little bit about them as a person. Are they married? Do they have people at home who might be able to help them after operations? Do they have any illnesses in the past that I need to know about? Are they on any drugs that I need to know about? Then I'll have a gentle physical examination. Because we tend to know by that point that the joint I'm interested in is arthritic, I'm fairly gentle with how I put them through their paces on the couch. I don't get too many complaints. And then we will either look at their x-rays or get some fresh x-rays to review together and see how bad their arthritis is and talk about what I would recommend in terms of treatment. And I think it's worth saying at that point that although hip and knee replacement are great operations for getting rid of the pain of arthritis, they're not right for everybody. Sometimes patients are a little bit too early in the process or are too young. When patients need a joint replacement, there are some slight limitations that we ask them to observe because the joint is artificial and not their own. So in the same way that the osteoarthritic natural joint has worn out through use, joint replacements can slowly wear out through use. But we almost always give patients completely free activities of daily living. They can do anything that they enjoyed doing before. So a lot of my patients get back to gardening, recreational walking, horse riding, cycling, swimming, doubles tennis, golf, dog walking, and all of those are positively encouraged to make good use of the artificial joint. There are some slight activities during gardening that we don't like people to do. We don't like people to dig with a spade after cemented joint replacements in particular. And there are some slight restrictions to the range of movement for the first few months after a hip replacement in particular. When my patients are listed for hip or knee replacement here at Circle, they're enrolled in an enhanced recovery programme which commences well before they come into hospital. They'll come along for pre-assessment and for joint school. We give them a very comprehensive guidebook specific to the hip or the knee replacement, which takes them through every stage of the process from pre-op optimisation through to their admission, everything that will go on in the operating theatre, on the ward afterwards, and the programme that they'll need to follow after they go home. And patients' feedback that this is really reassuring to know that it's really clear what's expected of them and what the process will be like. And the enhanced recovery programme has been shown to let people stay in hospital for a shorter time but achieve better outcomes once they go home. Here at Circle we work in clinical units, and I'm a member of both the hip and knee units. As a surgeon who no longer has an NHS appointment, it is really reassuring to know that I'm part of a group of high-performing surgeons who meet up, talk about their outcomes, talk about innovations and what they're doing, and model the pathways within the hospital so that they work for the best outcomes for the patients. A lot of my arthritis patients are worried about how long their life will be put on hold by the surgery. And with the enhanced recovery program that we have here at Circle, most of my patients go home on the second post-operative day. Patients often ask me, but when will I be better, doctor? And I used to say to them that by 6 weeks they would be better off than they were with their arthritis and would be happy with the surgery. But actually when I talk to patients and to my GP friends, they say that often it's much sooner than that, and even when they're seeing patients at 12 days to 2 weeks, taking out their stitches for instance, that they're free of pain and very happy even at that stage that they've had the surgery done.